let me go.
Okay, we're ready to go, guys. You can
Okay.
whenever you want.
Okay, good evening, everyone. This is Mary Vidal, president of the Peruvian Association of Clinical Engineers, which is a nonprofit association founded by the end of 2007 with a mission to promote the development of clinical engineering in Peru, also to assure the patient safety and to contribute with the humanization of the healthcare system. At this time, I had the opportunity and the honor to present the following teleconference, evidence-based maintenance, that was organized by ASPIC and the American College of Clinical Engineers as part of the Mutual Collaboration Agreement. This teleconference is going to be presented by Professor Binseng Wang, who is a referent in clinical engineering worldwide. He's also VP of the program management from Sodexo. Also, he's chair of the international committee from the ACCE, and also is member of the advisory committee from ASPIC. Professor, this is an honor. Thank you for this opportunity, and it's all on yours.
Thank you, Mary, and other ASPIC leaders for this great honor to address my dear Peruvian colleagues, as well as from what I can see here from the list of participants, several people in Latin America, as well as at least one person here in the North America. So this is a great pleasure. I want to first apologize for not speaking in Spanish. My Spanish is normally very poor, and now having not been able to speak for quite some time, I'm even more rusted than ever. So my apologies here. Hopefully you can understand me well. At the end, when you ask questions, please don't hesitate to ask in Spanish if you prefer, because I can understand fairly well. But if not, I'm going to ask Mary or Luis to translate for me. Okay, so appreciate that. Let's move on. As Mary said, this is the result of a collaboration between ACCE and ASPIC. So I want to make a very brief presentation about ACCE. You can find most of this information on the website anyway, but the basic idea is that this is one of the oldest association of clinical engineering in the world. Not the largest, but one of the largest. And we have a lot of international members, and we are trying to promote, obviously, engineering worldwide. And one of the activities is the certification that is given to the people in clinical engineering. And as I said before, we, ACCE, have a collaboration signed between ACCE and ASPIC, and this is a consequence of the hard work that the ASPIC colleagues have been doing there. And so this event is definitely a collaboration. Okay, I'm not going to talk about myself. Mary already introduced me, and also these slides are available to all the participants. So I'm going to just skip this over. And as well as the abstract here, you can read this much better, faster than me. So don't worry about this. I'm going to talk about what is really relevant here. But before I get into the subject itself, I want to make a few caution notes here. First, I'm not here to teach you or anyone here, but to share experience, because there are many, many differences between not only the Peruvian reality environment, but as well as from other countries or having other participants here. And so what we do in the US is unique to the American model of healthcare. And so it may not be totally applicable to you, but hopefully there is something useful for you here. Quoting the famous Galileo Galilei. He said that you cannot really teach a man anything, but you can help him find it within himself. So that's what I'm hoping to achieve here today. And also I want to, many of my American colleagues have different opinions about what I'm presenting here. And I encourage you to see from their perspective, because it will help you to understand what are the alternatives in doing the clinical engineering maintenance management that I'm going to talk about today. And I think the really important thing is for you to understand why we do what we do, because it's possible that what we do here may not be applicable to you, but some of them may be applicable to you. But most importantly, I think is for you, if possible, for you to learn from our mistakes. Don't get me wrong, we have made many, many mistakes, and that's part of the learning lesson. And so I'm going to quote a famous writer called Alexander Pope. He basically said that to err is human, to forgive is divine. And I would say, paraphrasing that, is to learn from one's own mistakes is smart, but if you can learn from mistakes made by others, that will be sublime, because you can save yourself a lot of trouble. Okay, so, oh, and above all, before I forget, don't copy United States. We spend a whole lot more money than any other country, and we don't have the best results. And this COVID pandemic that we are experiencing here is a clear demonstration that we are not much better than any other country. Okay, so today the presentation is divided into three big parts: the prior maintenance strategies, the evidence-based maintenance that we are going to cover today, some discussions and conclusions. And Mary had asked me to talk a little bit about the COVID-19 pandemic experience here, so I'm going to touch on that briefly at the very end. Okay, so from the prior models, the strategies that we have used here, probably one of the best known ones is called risk-based criteria, formed by my dear colleague because we used to teach at the same School of Engineering, Dr. Fenico, and one of his proteges, Ms. Smith, back in 1989. It was sanctioned, adopted by the Joint Commission. Joint Commission in the United States is the organization, the largest organization, I should say, that accredit hospitals, allowing them to get reimbursement money from the federal and state governments, the so-called Medicare, Medicaid program. This is extremely important because it represents a significant portion of the revenue of most hospitals in the United States. If you are not accredited by Joint Commission or a similar organization, you will not be able to participate in this program, and therefore your income will be severely limited. And this strategy here basically depends on this equation here. The equation says the equipment management number, EM, is the combination of three elements called function, physical, and maintenance requirements. Function, physical risk, and maintenance requirements, if adding them up, you will have a number. How the numbers are derived in a couple of seconds. But if the number is above 12, to include the equipment into your inventory, and should be called preventive, but I think it's actually should be scheduled maintenance, or either monthly, quarterly, semi-annually, or annually, according to this value here. If it's below this number 12, you can exclude, you can basically only repair the equipment as needed, okay? And the criteria is shown on this matrix here. Again, I'm not going to read every single one here, but just to point out that by categories, the therapeutic equipment or ventilator that you probably heard a lot about during this pandemic is therapeutic life support equipment, whereas diagnostic equipment, for example, a X-ray machine or CT, is a diagnostic equipment. And then analytical is for laboratory equipment. And then there are other miscellaneous equipment. So these are the functional scores that you will use, and down to 2. And then the physical risk, the second element of the equation, is whether it's going to cause death, injury, or other harmful effects to the patient. And then the maintenance requirements is classified in only 3 simple categories: extensive, average, or minimal. So if you add these numbers up, then you get that EM number that I mentioned before. Now, that risk-based criteria was very useful at that time. However, later on, we realized that both function and physical risk are actually estimates of the severity of the risk and not considering the probability of the risk. This is because the concept of risk is a combination of probability and severity. For example, if you have the misfortune, like me, of living near a nuclear reactor, you know that if the reactor goes boom, then a lot of people are going to die. It's an extremely severe type of risk. Now, on the other hand, if I am on a commercial airline flying, it's also a pretty risky proposition, because if the aircraft falls from the sky, several hundred people may die. Finally, the third category will be a automobile. If I am in a car driving and get hit by a truck, me and a few passengers may suffer consequences. So in terms of severity, the nuclear reactor is certainly the highest one. However, if you sit down and think for a minute, and you will see your risk of suffering any consequences of these 3 different situations is actually highest for automobile accidents. Then the next one is commercial airliners, and finally the nuclear reactor. Why? Why? The reason is because the probability is very, very different. The nuclear reactors very, very seldom go bad, and you can say, oh, but yeah, we had Chernobyl, we had the Fukushima Daiichi in Japan, etc. But if you go and research, you will see that those things are not exactly natural disasters, in the sense that the nuclear reactors went bad by itself, but because it was caused by something else. Okay, so the lesson here is basically we as clinical engineers and our colleagues and staff actually can only manage the probability. We cannot really change the severity. It's like you cannot change what a ventilator does or infusion pump does, and therefore the severity if it fails to function. But we can change the probability of that thing go bad because we perform maintenance in a good way. Okay, so also there are some other issues here that I'm not going to spend a lot of time here. Is the scope of harm, is the number of patients involved, is something that in the severity part people forget about, because one CT scanner is not the same thing as one infusion pump. Okay, and when you have a group of infusion pumps going bad, the scope of the harm is a whole lot bigger than one CT scanner go bad. And I'm going to come back and talk later about this model that is called Swiss cheese model of failure, but proposed by Professor Reason in 1997. So I'm not going to spend a lot of time here, but bear this in mind. A lot of you probably know this already, so I probably don't need actually to repeat that. So let's go back to the problem. The problem here is that the risk-based criteria was very good, but was heavily focused on severity and consider the probability well enough. Another strategy that became quite well known here in the United States in the last 15 years is the Reliability Center Maintenance, abbreviated as RCM. I'm not going to go through a lot of reading of the text here, but the important thing is to explain what this is about. We'll show you a diagram and then share with you what are the challenges that we see about applying RCM to medical equipment. RCM is well known in industrial equipment, production equipment maintenance, as well as, for example, in energy generation, etc. And it's well known and heavily adopted. However, we have a significant challenge here because to implement this in for medical equipment, this is not so easy. This, as I said before, became fashionable here in the United States because our Centers for Medicare and Medicaid Services, CMS, the agency, government agency that manage the reimbursement of the Medicare and Medicaid money, endorsed these things and said, oh, this is a good idea, except that they did not quite understand how this. So let's take a look how this process works to see why I'm saying this is a very challenging process. This is the decision process. Again, I'm not going to read every single block here because it's rather convoluted, but I'm just going to follow a branch of this so you can understand. So the first question is, will the failure be noticed? Okay, let's assume that yes, it will be noticed. So the next question is, can the failure harm a person or the environment? In most cases of medical equipment, the answer is yes. Otherwise, it's very rare in a hospital situation, that healthcare situation, that you have a piece of equipment whose failure will not affect a patient. So the next question is, can you perform preventive maintenance or scheduled maintenance to reduce the probability of failure to an acceptable level? Like I said before, we can only tweak the probability, we cannot change the severity. So if the answer is yes, then of course you perform the PM. But what if we cannot perform the PM and reduce the probability to an acceptable level? Then it says to redesign. As you probably know, in your respective countries, you probably have the same problem. We cannot redesign a piece of equipment. This is against the government's laws. In the United States, we have the Food and Drug Administration that says basically only the manufacturer or a remanufacturer can redesign a piece of equipment. Anybody else who does that is violating a law. So that becomes a significant challenge that we have. Coming back to the process of the RCM, we need to really understand the failure modes and effects analysis, understand what kind of failures they have, what are the consequences, in order to do that analysis I showed you before. And then we define the maintenance schedules and work instructions. Unfortunately, in order for us to do that, we need this information, and this information is not really available. Especially now, most of equipment is controlled by a software that is embedded by the manufacturer into the device. That software is proprietary, is totally transparent. You cannot really open that software. Even if they gave you the codes, it's very difficult to understand. And so there's nothing we can do about it. And even to get the maintenance schedules and work instructions, it's not very easy. At least here in the United States, I don't know about in Peru and other countries. I know in Europe, they are required to do that, to give you the information. So if they don't provide you with this information, you cannot really, even knowing the failure modes and effects, you have a significant challenge in defining the schedules and the instructions. So, okay, So what we do now in this situation, we use what we call evidence-based maintenance, and I'm going to explain how this thing works, okay? And a reference for you here is a book that I published in 2019, last year, and it's available through Amazon, but I'm not here to sell you a book. I'm here to explain this to you. I'm just saying that if you need more details, you can find it here. Or alternatively, you can read quite a few publications that my colleagues and I have made, as well as some clinical engineering professionals in Italy that have also implemented this process. And this process is now being implemented also in other countries, uh, but no publication has been made available yet. So let me explain what is evidence-based maintenance. The definition is rather abstract. It says a continual improvement process that analyzes the effectiveness of maintenance resources, structure, processes deployed in comparison to outcomes achieved previously elsewhere and makes necessary adjustment to maintenance planning implementation. You say, what the heck is this guy talking about? Too complicated, right? So I'm a person, I like to try to use a simple analogy to explain things. I like to fish. So in order for me to go fishing, I need to have a tackle for fishing rods, boat, okay? This is what we call structure. It's like your hospital. Your hospital have equipment, you have a building, you have facilities to perform the care. And the next thing we need is a process. My fishing process is for me to throw out lure to uh, food the fish to eat it, although it's not a real fish. This is a lure, not a bait, and try to catch the fish. This is a process. This is like your doctor giving you a surgery or a prescription. That's the treatment process that he or she will give you to treat your problem. And the outcome is I caught a fish. That proves that I am doing the right thing. Okay. Of course, someone may say, you're lucky. Well, that's why we need to make this process repeatable, and we need to get data to prove that this is not just a lucky situation. This is a outcome that can be reproduced. The same concept, for example, you must have heard many, many times about now drugs that are being used to treat COVID-19 or the vaccine that is being tested to make sure it works for COVID-19, right? It's the same process here. You have the structure, you have the process, but at the end of the day, you have to have outcome. And we are using the same process. Now, we evidently are trying to use the and same name as evidence-based medicine. Why? Because this is easier to understand, not only for ourselves, but for our colleagues. And the only difference that we need to tell them that our patient is not a human being, it's just a piece of medical equipment. Then they are not perfect. Your clinical colleagues say, oh, I see what you're trying to do. You're trying to use exactly the same type of methodology that we use for evidence-based medicine, but treating your patient, which is a piece of medical equipment. Okay, but in reality, both evidence-based maintenance and evidence-based medicine has much deeper roots. It's really, really well based, and that's what I'm going to remind you basically, because this is nothing really new. There is something called the scientific method. The scientific method is what you probably learned even back in high school or maybe even earlier, or middle school, when you first learned physics, chemistry, etc., biology. And one of the first persons who proposed this said something like this: "Y por si mueve." And since you know Spanish, it sounds very clear that yes, it's moving. And others follow him. And I'm showing you the Tower of Pisa here, and the person I'm referring to is Galileo Galilei. Okay, here is his statue. And but this is actually just the modern scientific method. This is actually something a whole lot older, according to a famous astrophysicist who you may have heard called Carl Sagan. And he argues that this is actually embedded in our genes after tens of thousands of years of evolution. We found ways to hunt, to cultivate the land, to find food, to build houses, to protect our families, etc. All these are actually experimentations and eventually proving that, hey, this works. This works is because that's the way the scientific method works and how we manage to grow the population of human beings on this planet and conquer adverse conditions of weather, terrain, etc., etc. Okay. All right. So let's go back to talk about our job here. Schedule maintenance. There are several different names, but the bottom line here is that we want to enhance the reliability of equipment. If we enhance the reliability of equipment, the equipment becomes more available and therefore it will become usable whenever there is a need to treat patients. And this will improve the patient safety and patient care. Because if the patient comes into the hospital, you don't have the equipment, it's like this ventilator issue during this pandemic, you are putting patient in jeopardy, right? So we have two basic types of work during schedule maintenance. One is truly preventive. We are going to replace wearable parts, and inspections for failures that I'm going to talk a little more in a few minutes, okay? And the counterpart to scheduled maintenance is corrective maintenance or unscheduled maintenance, meaning something that broke and we have to fix. To fix means really restore the equipment safety or functionality as soon as possible because we want to make the equipment, again, available, reliable to be used by the patients, by the clinicians actually for the patients. Okay, so reduce downtime. Uh, we want to detect failure causes, etc. I'm not going to read all this in detail because you will be seeing soon a table that really explains this much better. But one important detail I want to make sure that you understand, and this is actually now incorporated into a mandate here in the United States, is that a full-scale inspection, not so-called preventive maintenance, must be performed after each functional repair to ensure the equipment is safe and performing according to its original specifications after the repair. In other words, it's not just enough to repair. You have to make sure that the entire piece of equipment, every aspect of it is still working well because you may have inadvertently broken some other part of the equipment when you restore this part of the function, and therefore you could put out a piece of equipment that is unsafe for the users and therefore the patients. Okay, so we want to choose a strategy for maintenance, and so we call this maintenance planning. Okay, we have to plan for scheduled maintenance, and so we want to perform, as I mentioned before, preventive maintenance and inspections. The preventive maintenance is whatever is predictable. For example, oxygen cell or rubber gaskets will wear with time. We know that, so we are going to replace that before they fail. But also we need to find hidden and potential failures, because if they are there and the users are not aware of it, then they can end up harming a patient. Okay, so the scheduled maintenance is something that must be adopted as a function of the technology. Has nothing to do with the device risk or criticality as the old Fenico model implied. At that time, we thought, oh, anything that is life support needs a lot of maintenance. That's not true. Okay, I'll give you an example shortly and you'll understand. Here, for example, in the old days, we used to have the CRT tubes. I don't know how many of you good enough to remember this in TVs as well as patient monitors. Today, all the patient monitors is like your laptop are LED panels. CRT tubes had a well-known life for it's like your TV. It will die after a certain amount of time. It's like your light bulb because it's basically a light bulb. But LEDs are not. So your patient monitor in the old days to replace the tubes once in a while. But today, your LED monitors, there's nothing you can do about it. There's nothing you can do to prevent it from fading. In the old days, we used to have X-ray film processors. And today we have digital X-rays that use detector that is solid state. It will not fail by itself with a predictable manner. It's completely random. So there's nothing you can do about it. Whereas in the old days, the processors use chemicals, use mechanical parts that would degrade with time, and we needed to clean and replace, lubricate, etc., etc. And maybe this is a little too far-fetched analogy, but okay, if you have a standard car using gasoline or diesel engine, you will have to replace oil, etc. Now, if you have an electrical vehicle like a Tesla, okay, you don't need to change oil because there's no oil to be changed. The motor does not need oil to run. It does have some lubrication, but it's a sealed lubricant inside. Okay, so in other words, the so-called scheduled maintenance depends on the technology, does not depend on the patient risk level. Okay, so put this into your notes. Severity, the higher the severity does not mean higher scheduled maintenance needed. Okay. Okay, corrective